Furthermore, AV septal defect with a typical mixing up of blood and not always seen on grayscale, especially that when it is small. And one of the most important images we can look at when we look at the 5-chamber view is when we detect an overriding of the aorta. So you see here in this picture that both ventricles are linked to the ascending aorta, and blood will flow from both right and left ventricle across the VST into the ascending aorta, leading to stillation. So in general, people say, oh, I see overriding of the aorta. I'm sure it is a tetralogy of Fallot. But this is not yet the case. It is the most common condition. But when you see this, you should seek for other signs, especially what is happening with the pulmonary artery. Is there a pulmonary stenosis? Then it's a tetralogy of Fallot. But then, by knowing the size, the origin, and the blood flow within the pulmonary artery, you can get to the final diagnosis, one of many. So this is why please consider the overriding of the aorta, confirm with color Doppler as a hint, and then see what is the pulmonary artery doing. So if you see this condition, go to the pulmonary artery, and what you see here is a narrow pulmonary artery and connecting to the aorta, and this narrow pulmonary artery with antegrade flow is typical for pulmonary stenosis, and thus is the third sign of tetralogy of Fallot. Another condition where the pulmonary artery in this overriding situation is quite enlarged and shows turbulences is the absent pulmonary valve syndrome, which makes 1% of all tetralogy of Fallot. So quite rare, but prenatally easily detected because of the large absence of the ductus arteriosus. Often you see here 1 out of 3 cases have a right aortic arch. You see the aorta on the right side of the spine, and almost 50%. Another condition when you think there is an aortic of same what you assume to be the aorta, which is then a common arterial tracing for many, is the transposition of the great arteries. In this group, you will be using color Doppler to demonstrate the parallel course of the vessels, which is not always very easy to discover on grayscale. But you see the typical is the oblique plane showing the 2 parallel vessels, and then getting a 3D will demonstrate in comparison to what I showed you before on the crossing of the vessels in the first image on 3D I showed you at the beginning, that you see here 3 different ways of demonstrating the parallel course of the vessels in the transposition of the great artery. Similar disease where you have almost similar parallel course is in double outlet right ventricle. But here in the difference to what I showed you before, we don't have the arteries arising separately from left and right, but we have the 2 vessels, aorta and pulmonary artery, namely arising from the right ventricle. So this is why it's called double outlet. It means the double origin of the great vessels from the right ventricle. And you see here on this video clip how it appears, how the 2 vessels are Doppler and the inversion mode, how it can be demonstrated. Now, one of the challenges sometimes on 2D and on grayscale and sometimes on color Doppler is when you find instead of having the aorta to the left side, you have the aorta to the right side of the trachea. This can be as this V sign to the right completely, quite rare to be seen, or you have what we call the U sign, the aorta on the right and the pulmonary artery on the left, where the trachea is in between, or we have a double aortic arch. That means the aorta go to the right, but bifurcating before, so it leads that to the situation that the trachea is really between the right and the left aortic arch. Often is the trachea compressed, and sometimes you have one of the 2 branches, mainly often the left one is narrow. So this is why, how do we see it on grayscale and on color Doppler? The color Doppler shows you easily that there is a gap between both vessels. So instead of the blue V sign, we see here typically what is called the U sign, like the letter U, with the trachea between both. Conversely, if you see here no bifurcation. If you have a fetus with a double aortic arch, what you see here, as I told you, is bifurcation of this right arch. And you see here like a second vessel in front of the trachea. So at the end, it is here around the trachea. But often in this plane, you don't see the continuity behind. So this is why you are not sure, is it open, is it closed? And this is why by using 3D in these features, you can see in the right aortic arc in the so-called U sign, you see here the right aortic arc with the pulmonary artery with bifurcation. And we see here in different demonstration tools, whereas in double aortic arc, you have an additional vessel here, as you see. You see the right arc and the tiny left arc. You see the trachea entrapped between, and this is here on the stick. You see the narrow left arc and the normal right arc on the right side. So you see that by really good using the color, you can get to a good diagnosis by using combination of color Doppler and 3D. Now, tiny vessels, I don't mean also the early gestation, but for example, situation like this one, where you see behind the trachea, there is an aberrant subclavian artery, abnormal course of the right artery to the shoulder, situation present in 1% of the normal population on one hand, but very commonly found in fetuses with Down syndrome in almost 20% of the cases. So this could be used as a marker to be used in addition to other features. Or for example, in situation with the pulmonary atresia with VST, we know that there are aberrant vessels arising from the descending aorta, and these are called MAPCAs. And you see here nicely how out of the descending aorta we have bifurcation of two vessels arising directly into the lung. So a lung perfusion through separate arteries called MAPCAs, and adding the color Doppler. And show you another case here of such a situation here. This here was sent to me because of a tricuspid regurgitation on color Doppler, and I assume the colleague did not examine this fetus on grayscale. You see here there is regurgitation, and then before discussing with you the long list of possible regurgitation, switch off the color and look at the heart. And what you see here is a myxoma between, let's say, moving between the atrium and the ventricle and leading to this regurgitation. You can better appreciate on grayscale. So this is why always examine first in grayscale and color Doppler, and any abnormality on color Doppler, return back and try to assess on grayscale. Or let's say another quite complex anomaly is this one. What you see here is the filling of the four-chamber view, and you will say, I see it. It looks normal. But if you look at the grayscale picture of it, like this one, you will appreciate that what we have here is an AV discordance. You see what we have here is the right atrium connected with an anatomical left ventricle. And here is the left atrium with the lung veins connected with an anatomical right ventricle. You see also the moderator band is present on the left. Now, on grayscale, you will appreciate that the heart apex is not formed by the left ventricle anymore, but by using color Doppler like this one here, you will not see this difference quite nice. You see two chambers and you assume it's normal, but look at the right side, the left side, and you can see the anatomy is quite abnormal on the grayscale. In general, you will detect this anomaly when you look at the great vessel, but I want to show you that even you assume it is well seen here, the color is covering the information you need. So I hope I showed you this overview. First, part one was on how to do the presets. Remember to reduce the gain and to make the box smaller, as you see in these images. I showed you anomalies of the four-chamber view, differentiation between different ones. Remember the AV canal, small left ventricle, small right ventricle. Then we moved to the great vessels. We discussed the overriding aorta and other right aortic arc versus double aortic arc. And then we discussed also the tiny vessels. And last but least, I showed you also some pitfalls if you focus only on color Doppler and not include the two. This is why take-home message, if you see the four-chamber view by using the color Doppler with the two stripes, you can identify most of these conditions we discussed today: VST, AVST, double inlet ventricle, dextrocardia, for example, coarctation, hypoplastic left heart, and so on. And for the great vessels, I showed you examples of aortic stenosis, of overriding of the aorta with the tetralogy of Fallot, transposition of the great arteries. Remember also the coarctation, the right arc versus double aortic arc. And all these features, if you know how to use the color properly, you can use them in registration. You see here the AV septal defect, the double inlet ventricle, the right aortic arc, the absence flow in the right ventricle, and the narrow left ventricle comparison to the absent left ventricle. And I hope you have enjoyed my talk, and I hope you have many questions. If you want, I can answer them afterwards. And this is here my thank to you, and hope you have some messages you can use during your everyday scan. Thank you very much.
Thank you very much, Professor Shawi. انت معانا بروفيسور شاوي؟
انا معكم. انا عم شوف بس البطن والارض. مين الدكتور محمد؟ مين عم يحكي؟ شايف شيء؟
Not yet. Morning, Professor Shawi.
Morning. How are you?
Fine, thank you. I miss you.
I just saw the audience.
We want to be together here in Cairo, but I know it's nearly impossible with this pandemic.
I know.
I hope that everything goes well. So, first of all, in our conference,
thank you.
And the attendants, maybe they will have some questions. Anybody has questions to Professor Shawi? Okay.
How are you?
Hi, how are you?
Good talking to you.
I saw that you have a talk.
Argument is that the hard examination will take long time during anomaly scan. Can you please reassure us how much time do you need to examine in a normal antenatal setting? How much time do you need to look at the heart?
So, well, this is a good question and provocative question at the same time. In general, you have to distinguish at the beginning, is it a patient with high risk or low risk screening? If it's high risk, you may need to do more, but in low risk, you do mainly the essentials. I say often that I recommend you to be opportunistic in your scanning. That means if the baby is in a good position where it's dorso-posterior, you can get through the heart within less than 1 minute, because you start from the upper abdomen, you tilt to have the 4-chamber view, valves opening and closing, 5-chamber view, 3-vessel trachea view. Add the color, do the same in systole and diastole, and that's it. It is the same fetal position where you see the face. I cannot imagine that you send any woman home without having a profile. Many people in the world are concerned about Down syndrome, but the chance of having Down syndrome, if you are younger than 34 years old, is 1 to 300 and less. So it is larger to have a chance to have a cardiac problem than Down syndrome. This is why I insist of having at least the 4-chamber view in color and the great vessels crossing. So 1 minute, 2 minutes, but if the baby is not in a good position, then you have to go left and right. It's true, but you cannot say I examined the baby and I missed, let's say, a complex cardiac malformation, and the baby dies, and you say, I'm sorry. And you should say, repeat it again. And often, in many countries, like in ours, where decision-making is rarely to be permitting pregnancy, but rather preparing birth or preparing, let's say, the situation after birth, even if you do not see it, you can postpone and having later on examination, 25 weeks, 26 weeks. Thank you, Dr. Badruddin.
Can I ask you a question?
Yes.
Can I?
Yes, please.
Sorry, Rabi, I get back to you again. You know,
I'm here for you.
I have a keen interest on stick technology. And
Yes.
I do a lot of stick, and I blame you for this because I learn from you. You give me inspiration to look at the heart. Really, that's very true. I look at the G illustration, and that's how I learn to do stick from your experience. I'm really surprised why stick is not taking over. Something like OmniView or biplane, which I learned from you, which I found sometimes quite time-saving and quite good tools which you can apply for everyday practice. But I'm so surprised it's not take up in a big time. Thank you.
Yeah, you are absolutely right, but this is in technology always the case. You have, I don't know if you know the hype cycle, there is a curve where it goes up and then it's forgotten and it will come back. You will see it will come back. But let's say to your and my experience, stick technology, biplane and so on, are very well in hands of, let's say, semi-expert or expert, and they often need the fetus in a good scanning position. And this needs some expertise, and this is why many people are still hesitating in the way. So I'm happy that we did it. I'm also happy that many people are using this approach, but it's at the end of the day, let's say nothing where you can sell people it's part of the screening, you should do it. But in expert hands, it's really recommended, and I've showed you in my talk images on stick and on these with the 3D, and they describe excellently the situation. Look at the cases with right arc and double aortic arc, or cases with abnormal lung vein, where you see the two vessels, the vein and the aorta side by side on a 3D picture, which is easier done than the other one. Yeah, you cannot see if there is any hole in the wall. So this is why I will describe only either in association with other conditions, or if I see, let's say, as an example, when it's almost absent from ovale flap. So this is why, let's say, but on the other hand, I'm not really interested in teaching people, these difficult things. I want them to have a simple, the most common anomalies detectable on the fourth chamber great vessels. They are by far more important. The other one is an add-on. Now, for the second part, abnormal lung vein drainage, the partial one, I've seen very, very few children with this condition. As long as enough blood is going to the lung and exchange it, you don't need to do anything in early surgery, but you may need a little bit later on when there is some cardiac, let's say, hemodynamic disturbance. So in general, they are not operated before the 1 year of age. But for the total anomalies, you should distinguish between two groups. One, when there is an obstruction. Obstruction means infracardiac is almost always an obstruction because it goes into the liver, and there is at some stage, let's say, not enough blood returning back. And after birth, when there is more blood to the lung, there will be at some stage some stop somewhere. And this is really a nightmare for pediatric cardiologists, because if you don't have the diagnosis, you give oxygen, they do not recover, and you lose often the baby. So I ask sometimes patients to come to see me because of a previous history. They tell me, yeah, I lost my baby. After 5 days, no one was knowing the diagnosis, and then at autopsy, they saw it as abnormal lung vein. Postnatally, it's really difficult to clear part of the heart because they think it's some pulmonary hypertension and so on. So this is why they need your approach. If it's not obstructed, it can support for, let's say, some weeks. And the last child I saw with a complete lung vein anomaly without obstruction was operated at week 4. And one of the cases I showed you was operated 3 weeks ago at day 3, day 4 with the infracardiac one. It is worth to make the diagnosis.
Of course. Thank you. Any other questions, please? Okay, Professor Shawi, the floor is satisfied.
Thank you.
And we are all satisfied by
You can
this.
ask me by a coffee. I will go and have coffee with you, and you'll ask me there the next question.
Okay. Thank you very much. Bye-bye.
Bye-bye.
See you in person next year, inshallah.
Thank you, and يلا إن شاء الله المرة الجاية بالقاهرة.
Inshallah.
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 يلا.
Thank you, Dr. Rabia, for being with us. And I know it's hard time for you and it's a working time, but thank you. I appreciate your effort with us. Thank you.
Thank you. Thank you for the invitation.
Okay, bye-bye.
Have a nice time. Be careful. Stay
Okay,
safe.
inshallah. Bye-bye.
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 Inshallah.
Okay. I'd like to thank GE Company and its team for their support in this session. وعلى رأسهم طبعا دكتور هاني يوسف المسؤول عن مينا ريجون واللي جه مخصوص عشان يسبورت المؤتمر. وبرضه حابب اشكر شركه الكان ميديكال، مهندس تبارك والتيم اللي معاه كله، لان هم نظموا السيشن ده. وفي سيشن تاني ان شاء الله بكره بعد الصلاه، دكتور جهاد من فرنسا، اتمنى تحضروا.
مساعد وكان بيعلمني وكده. Alright, this is a sponsored session. Alright, this is a sponsored session. يعني هي لصالح شركة E.F.M.F. فهنبص على بعض الحاجات هنا. We'll look at a few things about antioxidants and omega fatty acids they use. There are no strict guidelines on this, so you can شوف, form your own opinion. Alright, now if we have oxidative stress, alright, we have cells, then we have free radicals attacking the cells that can cause death of the cell. Now, does this happen in the male? Probably. In the female, probably. All of us will happen to us. Yani. We will all die from this eventually. Eventually, superoxide ion would kill us all. كلنا عارفين, everybody knows that males فقدوا half their sperms. Yani, we all know that men have lost half their sperms. When I was young, we said normal sperm count is 60 to 100 million. Now it's only 15 million. So we have lost half our sperm. So if we have too many reactive oxygen species, these can cause damage to the cells. This can damage the accessory glands, can damage the spermatozoa. Why do we have these things? Too much smoking, too much pollution, pathologies, diabetes, systemic infections, and so on. So we have a multitude of factors working against us, especially males. And these can cause oxidative damage to our reproductive capacity. What can we do to that? We can try to treat the pathology. Diabetes, good luck. Obesity, good luck. Systemic infection, stopping smoking. In fact, some toxicity, كلنا عارفين, paracetamol poisoning is probably due to excessive damage to the GSH. So this is important. I'm using it to defend myself, but if I use it too much, there will be negative consequences. So excessive reactive oxygen species or not enough antioxidants can cause damage to the DNA, the proteins, lipid peroxidation. This can cause cancer, but for us can cause other stuff. Now, is there evidence? I know these are a little bit old, but some people, vitamin E in males, improved IVF. Vitamin E in males, increased pregnancy rate. Folic acid and zinc, sperm count is getting better. Vitamin C, vitamin E, boost sperm DNA. And they improve the antioxidant defense, improve oxidative stress, and oocytes and embryos can be better. Okay? Can even improve ART, and we all know the expense of artificial reproduction. All right, a single cycle in Egypt costs average 15 to 20,000 pounds. So giving a few antioxidants. Are there any other problems from this oxidative damage? This oxidative damage can worsen polycystic ovarian syndrome. The inflammation increases, so endometriosis increases. Pain with dysmenorrhea increases, and the negative effect on fertility and pregnancy continuation can be there. So reactive oxygen species, by the generalized tissue damage and the damage to the developing gametocytes, is probably bad. Let's look at PCOS, one of the main causes of PCOS. Let's look at glutathione in PCO. Now we need this for everything. In controls, glutathione level is here. In PCO, it's down here. This proves that we are using our glutathione. We are using it to defend ourselves against excessive oxidative damage. Why use it? Why don't you supplement? In endometriosis, some studies, not many, say that we can improve inflammatory reaction. Now, let's look at selenium. Selenium is an antioxidant, but it's very good in hypothyroidism. The rate of hypothyroidism in Egypt is around 30%. It's much more common than diabetes, especially subclinical hypothyroidism. Diabetes, we have a 14–15% diabetes. Hypothyroidism is much more common. Selenium is important for thyroid function. Next, recurrent pregnancy loss. We can even give it for recurrent pregnancy loss. In pregnancy, we really want omega-3. Okay. There are other functions of omega. Omega is EPA and DHA. We all know that part of our nerve cells